It's the Pain Exam Podcast with your host, David Rosenblum, MD. If you treat pain or have an interest in pain management, join us as we discuss painful disorders, alternative treatments, practice management, and more. Be sure to subscribe to the Pain Exam newsletter at painexam.com and review the podcast on Stitcher or iTunes. Our high-yield premium episodes are now available on the Pain Exam app with a premium subscription, or access for free with a CME subscription at painexam.com. And now, without further ado, here's your host, Dr. Rosenblum.
Okay, welcome back to the podcast. I'm so happy you guys could join me. Before I get into any of my planned announcements and discussions, please take a moment to review the podcast on iTunes, Stitcher, Spotify, whatever you're listening to this on. And if you're a Pain Exam member, or go to my courses, if there's any emails or pings to review it, I really would appreciate it. Hopefully a positive review. If it's not positive, please let me know how I can improve the experience. And speaking of experiences, we have some great conferences coming up. You have ASIP coming up, and that's going to be on March 16th through 18th. It's the annual meeting in Maryland, and they always have a great conference. Go check out their website. In the summer, you have Aspen, which is also fantastic, and that's July 13th to the 16th at the Fontainebleau. It's a different venue this year. And in the fall, we have NICIP. We just finished NANS, and of course, there's all sorts of other great conferences out there. And my courses, I just finished a regenerative medicine course last weekend, and we had a solid group of 10 docs, and we, for the first course, it went very smooth. I covered the basics, the science behind the various biologics, legal and ethical concerns, as well as applications for various painful disorders, orthopedic problems, and the evidence to support it, as well as some pearls and ultrasound imaging to get in there. Speaking of ultrasound, I'm going to be in Canada this weekend doing a private one for pain care clinics. They have 30 doctors there and nurses, and I'm looking forward to that. Going to be in San Juan after that, and Costa Rica doing courses, as well as in my office in New York, March 11th, April 22nd, with another regenerative medicine course Saturday, May 13th. If you couldn't make the first one, try to make the next one. And then finally, our board review course. Ala Abdul Saeed and myself, we're going to be in Manhattan in June doing a 3-day course, 2 days of in-person board review. Day 3 will be Zoom or on-demand playback, and the ultrasound course will be day 3. So it's a combo hybrid course. Also hybrid in the sense that there's going to be a Zoom if you can't make it. It's very valuable. The people who did it last year were pretty happy with the content and passed the boards. So I highly recommend it. And speaking of passing the boards, check out painexam.com, the revised anesthesiaexam.com, and pmrexam.com. So now let's get into the practice. I have a patient who I'm struggling with. She came to me with a diagnosis of postherpetic neuralgia after her rash. I did not witness her rash. She did have some skin changes afterwards. So I didn't question the diagnosis too much. Now I'm starting to question it because it's just been going on for 5 or 6 months, and I'm throwing the kitchen sink at her, and I'm still struggling. This patient started with non-opiates, all the neuropathic pain drugs, the gabapentin, the Lyrica, the Cymbalta. She had paravertebral nerve blocks. She had the capsaicin patch, Qutenza, which she couldn't tolerate after 40 minutes, even though we pre-medicated and put lidocaine on before. She couldn't tolerate it. Eventually, she came in desperate. I had some samples of a cream with lidocaine, menthol, a little bit of capsaicin, not nearly as much as was in that cream, and a salicylate. And she had the most intense burning pain, writhing, screaming just from this cream that I gave her a sample, and I didn't expect her to put it on in the office, but I stepped out of the room. She put it on herself, and the pain was going down her arm and the armpit and was quite severe, necessitating emergency room admission. And they gave her morphine and ketamine in the ER, and the ketamine appeared to help, not surprisingly. But I'm still wondering. I told her, I'm like, I need to get you imaged because I'm worried I'm missing something. I mean, yes, it could just be postherpetic neuralgia, and probably is, but I need to make sure there's nothing else going on with her, and her allodynia and hyperalgesia are way out of proportion, almost acting like a complex regional pain patient, to be honest. And so I'm already starting to think of what else I could help her with. But I also wanted to get a further workup. So that's where we stand with this patient. And what's going through my mind is possibly a peripheral nerve stimulator or some other therapy. But I did inform her that she needs to see a neurologist and get imaging done because I want to make sure that there's nothing else going on, especially since I never witnessed the active rash from the beginning. And her dermatomal pain was thoracic with some armpit spread wrapping around the upper back to chest. Okay, so let's just get into shingles or postherpetic neuralgia. It's chronic, persistent, debilitating. By the way, I'm using a 2019 Pain Physician Journal article as reference. Interventional Treatments for Postherpetic Neuralgia, a Systematic Review, written by Dr. Lau, Dr. Lau, and Dr. Chen. So, and these guys are in Taiwan. So, to get to the point, this is their conclusion. They'll get into all the details. They mentioned that with the exception of intrathecal methylprednisone injection for postherpetic neuralgia, the evidence for most interventional procedures used to treat postherpetic neuralgia is level 2, according to the Oxford Levels of Evidence 2. Therefore, these modalities have received only grade B recommendations despite the lack of high level of evidence. Spinal cord stimulation and peripheral nerve stimulation are possibly useful for treatment of postherpetic neuralgia. So still scratching our head, but the article gives a nice overview of the disease. So I'm going to get into that. So these patients have a chronic debilitating condition associated with itching, lancinating, sharp pain, frequently allodynia, hyperalgesia in the areas of anesthesia, and deficits in thermal, tactile, pinprick, or vibration sensation within or extending beyond the margins of the affected dermatome. Generally, the risk of developing persistent severe pain is fairly low among primary care patients who've recovered from a herpes zoster infection. At 3 months after the onset of shingles, patients less than 60 years have a 1.8% risk of postherpetic neuralgia, whereas those aged over 60 years have risks of 3.3% after 12 months. Despite the low probability, however, severe postherpetic neuralgia is considered intolerable by the affected adults. It's initially treated with medication. The European Federation of Neurological Societies level A evidence for both first and second line medication therapies include tricyclic antidepressants, serotonin norepi reuptake inhibitors, pregabalin, gabapentin, tramadol, capsaicin, 8% patches, and lidocaine patches. And the numbers needed to treat of these medication therapies ranges from 11 to 25. Patients who experience persistent pain despite conservative therapy undergo interventions. And despite the perceived benefit to our knowledge, no previous review has focused on the efficacies of these interventional procedures to treat postherpetic neuralgia. So the rest of the article gets into how they did their review. The interventions talks about patients receiving an injection such as local anesthetic, peripheral nerve block, neuroaxial block, and stellate ganglion, nerve stimulation such as transcutaneous electrical stimulation, peripheral nerve stimulation, and pulse radio frequency, spinal cord stimulation, and destruction of the dorsal root ganglion. The controls were basic drug treatment without any interventional treatment considered, and the outcomes the studies enrolled should include basic information. They review all these different studies. For each intervention, systemic reviews and meta-analyses were considered first, followed by randomized controlled trials, observational studies, and then case reports if no better evidence was available. So they have a nice chart, and I'll have the link in the show notes. They look at groups or studies, randomized controlled studies with double-blind with Botox A, lidocaine, saline, Botox A versus saline. They have another one with pregabalin plus TENS, pregabalin plus placebo, TENS plus cobalamin, lidocaine, or cobalamin and lidocaine, then TENS versus sham. TENS antivirus. I'm not sure what type of antivirus. I guess the herpes antivirus, that would make sense, but I'm not sure what exactly they mean by it. I don't know much about it, to be honest. Triamcinolone lidocaine versus lidocaine alone. Intrathecal, epidural, and then more. There's some more other studies with lidocaine and methylprednisone. And so let me just get to the point here, because I'm not giving intrathecal doses of steroids in my practice, and I'm curious about this. They also did fluoroscopic guided lesion of the DRG, ultrasound guided paravertebral puncture. Ultrasound guided paravertebral puncture. I do paravertebral nerve blocks. Oh, and then they're doing, it looks like they're pulsing at the paravertebral space. So they're probably doing DRG pulsing, it looks like. Then intercostal nerve blocks and ultrasound-guided lesion in one segment of the adjacent DRG. Lots of pulsing of the DRG here. Then there's T3 barbiturate, ketamine. They don't go into the details of each individual study. They're just listing them in some of the findings, which I really think you guys should look at yourself. I'm really more interested in their summary and their conclusion as to what works, because, as I mentioned earlier, I'm stuck with this patient and I'm trying to figure out what's best. So when they evaluated all the outcomes of these studies and summarized the modalities in their findings. So subcutaneous Botox A injection. It's a neurotoxic protein purified from Bacterium Clostridium botulinum. The L chain, which exhibits ZN2 plus dependent protease activity, selectively cleaves synaptosomal nerve-associated protein 25 to inhibit the release of neurotransmitters, including acetylcholine and substance P, from motor and sensory neurons, respectively. Additionally, Botox reduces peripheral nociceptive output by inhibiting the release of glutamate, a peripheral neurotransmitter involved in neurogenic inflammation. So they had 2 randomized double-blind placebo-controlled trials evaluating the effectiveness of it for persistent moderate to severe postherpetic neuralgia. They injected 1 to 2 centimeter radius over the painful area, and the maximum dose did not exceed 200 to 100 units. And they saw benefits in both studies include improved VAS score and sleep duration and reduced number of patients using opiates. The effects emerged at 7 days after injection and persisted for 3 months. And so this might be something useful I could try with my patient. I've never given Botox for this, but I know of neurologists using Botox for neuropathic pain conditions. They looked at TENS, and there was possibly some benefit. You could look at that yourself. I'm more interested in the interventions, since TENS is kind of a low-hanging fruit that you could easily prescribe, and they could try it. It did not work for my patient. Local triamcinolone injection. So peripheral sensitization involves neural damage and inflammation with subsequent edema consequent to the varicella zoster virus reactivation is among the mechanisms underlying the development of postherpetic neuralgia. In this process, the injured tissue releases inflammatory mediators that reduce the nociceptive threshold and thus activates peripheral nociceptors. Corticosteroids may ameliorate postherpetic neuralgia by modulating this inflammatory process. One randomized controlled trial reported a relief rate of 100% of patients with postherpetic neuralgia who were treated with local intralesional injection of triamcinolone plus lidocaine. All patients received 3 injections at 2-week intervals and reported pain relief at 6 and 12. These time points correspond to significant improvements in pain, as indicated by the respective NNT values of 2.1 and 1.3. And NNT's number need to treat. However, this extremely high relief rate might be attributed to exclusion of patients with refractory conditions. The trial was conducted in a military hospital. It remains to be proven whether these improvements are reproducible in other populations. However, that's kind of low-hanging fruit, right? If you could just inject some triamcinolone into the area of the pain, as they're saying, and get 100% relief rate, I'm a little skeptical about this, because it just seems too easy. But I might try it. You guys got to look at this article. It's pretty interesting. Intrathecal injection of methylprednisolone with local anesthetics or midazolam. So they're talking about pathology with in these patients revealing subacute or chronic inflammatory process involving infiltration and accumulation of lymphocytes around the spinal cord, suggesting inflammation may play a role in the development of postherpetic neuralgia. Furthermore, patients with postherpetic neuralgia have relatively high interleukin 8 concentrations in the CSF, a factor that was shown to correlate inversely with the duration of postherpetic neuralgia. A possible anti-inflammatory role for methylprednisolone is further supported by the ability of intrathecal methylprednisolone administration to reduce IL-8 concentrate. Well, I'm not sticking any intrathecal needles into the thoracic spine, thank you. So I don't imagine many of you will do that either. I know you can do it, and people have done that, but that just sounds too risky. 3 randomized controlled trials have investigated the effectiveness of intrathecal methylprednisolone for intractable postherpetic neuralgia. It's defined as persistent pain regardless of use of antidepressants, anticonvulsants, NSAIDs, epidural, local anesthetic, topical agents, and physical therapy. The earliest randomized controlled trial published by Kikuchi et al. Compared the intrathecal versus epidural injection of methylprednisolone and found that the former reduced pain by 50% at either 4 or 24 weeks after injection. The largest randomized control published in 2000 also reported promising outcomes. Here, although intrathecal lidocaine significantly relieved pain by over 50% at the end of treatment, intrathecal methylprednisolone yielded superior pain relief both at the end of treatment and after 2 years. In both studies, the injections were administered once weekly for 4 weeks, and the need to treat was 2. By contrast, the most recent randomized controlled trial of this modality was terminated because of safety concerns and futility by the 6th patient in the treatment group. I mean, it's not just risk of a needle stabbing the spinal cord with this. You're also risking preservatives into the thecal space and the potential risks of adhesive arachnoiditis. So there's a lot to consider if you're thinking about sticking a needle into the thecal space to treat this. Also, remember the level you're at. If it was lumbar, I think more people would be doing this. But thoracic, I'm not running to do this at all. And so I don't encourage you. They do mention that there is a lack of causal relationship between these preservatives of the methylprednisolone, and they list the preservatives here. They call it myristyl gamma picolinum chloride and polyethylene glycol, which don't sound like nice things to put in your thecal space. They said there's a lack of causal relationship between these preservatives. Intrathecal methylprednisolone should be administered after careful assessment of risk to benefit ratio. Of course, always assess risk to benefit ratio. Intrathecal midazolam was associated with meaningful improvement in pain, allodynia, sleep quality, and changes in the areas of allodynia. However, general pain relief was only observed during 1 week in patients receiving intrathecal midazolam alone, whereas administration in combination with epidural methylprednisolone yielded good pain relief for 12 weeks. In contrast, other protocols, this study administered only a single injection. I have done epidural steroid injections for this, and I have yet to do this on this patient. I think I'm going to get an MRI first before I do that. That might be a way to go. I remember being in fellowship when we were quoting a study, a journal club, in which patients who received the epidural steroid during the acute onset of the illness of the shingles, I guess, pain did better with less recurrence. Or it was actually right after the breakout happened, the rash. So I'm not going to talk about that study because I don't remember where it's from. I did do this on a resident of mine who developed an acute zoster rash and was having dermatomal pain, and he did very well. So there might be something to investigate with respect to that. That's an old study, so I'm looking for better studies, and I'm just not telling you to do that. I just want you to understand that this is a very difficult disease to treat. Now, this is something I didn't try yet on my patient, but since she has pain going down her arm a bit, it probably needs to be evaluated, and that's a stellate ganglion block, right? Sympathetic nervous system is an important mediator of pain, After nerve injury or tissue inflammation, collateral sprouting in the peripheral and dorsal root ganglion, and the upregulation and functional adrenoceptors may lead to the formation of anatomic and chemical coupling between the sympathetic and postganglionic and afferent neurons. Sympathetic terminals also contribute to the sensitization of nociceptive afferents. However, the mechanisms by which the sympathetic nervous system affects postherpetic neuralgia is still uncertain, and I'm reading this directly from the text. So here they're talking about patients who had postherpetic neuralgia, mainly of the face. They did the block. In the study that they're talking about, patients received 150 of pregabalin twice daily, in contrast to other studies in which analgesics were only administered as a rescue therapy. Notably, the authors observed significantly reduced incidence of postherpetic neuralgia and higher satisfaction scores in patients who received the block. Patients reported significant decrease in VAS scores from the first follow-up to the last follow-up from first week until 6 months post-injection. The group receiving and not receiving the stellate ganglion block also exhibited significant differences in the required dosages of acetaminophen and pregabalin beginning at the first and second weeks of follow-up. Those receiving the block stopped using pregabalin, and acetaminophen after 2 and 6 months, respectively. All right, DRG destruction, dorsal root ganglion destruction. So they looked at pathology in patients who have loss of cells, axons, myelin, and concomitant fibrosis in the sensory ganglia. With severe postherpetic neuralgia, the pain sensations may be caused by ectopic discharge of the nociceptors and low threshold afferents at the dorsal root ganglion. Adriamycin, doxorubicin, is an anthracycline topoisomerase 2 inhibitor associated with cytotoxic effects such as apoptosis, autophagy, and necrosis. It's not specific anti-tumor drug and therefore can be used to affect the growth of cells in the body. Potentially, it could be used to destroy the DRG and thus relieve pain by disrupting the related signaling pathway. Of course, it's only approved by the FDA for certain malignancies, but the destruction of the DRG is off-label. They treated patients with adriamycin and dexamethasone and improved VAS score and short-form McGill patient questionnaire scores relative to both the baseline and control groups. The effects began after 1 week of treatment and persisted for 6 months, although patients treated with dexamethasone alone also reported reduced pain and improved sensory and psychological function related to baseline. These improvements did not persist beyond 3 months. Polestar FA, I'm going to just get to the end of this because most of us know about this. Meta-analysis had significant pain improvement after 1 day, 1 week, and 1 and 3 months with only minor adverse events. Spinal cord stimulation, most of us know how that works, so I'm not going to get into that. And there's some varying results with respect to the studies that they're mentioning, so it's not here nor there, to be honest. I guess it's kind of a last-ditch effort, or one of the last-ditch efforts. I do want to focus more on PNS, and the central mechanisms underlying postherpetic neuralgia include necrosis and scarring of neurons in the DRG and inflammation involving both the anterior and posterior horns of the spinal cord. However, the pathophysiology of postherpetic neuralgia also involves a peripheral mechanism according to gate control theory of pain. Postherpetic neuralgia may be a type of deafferentation pain, and therefore the peripheral nerves may be possible treatment targets. PNS may be a solution for patients with intractable postherpetic neuralgia, especially those experiencing neuralgia of the cranial nerves, which obviously cannot be treated with a spinal cord stimulator. There's case reports revealing successful use of PNS for pain reduction in patients suffering from postherpetic neuralgia of the supraorbital and thoracic regions. The patients would get a diagnostic block to identify the segment in which temporary electrodes would be placed and a permanent pacemaker was implanted subcutaneously after trials. The stimulation settings include a pulse width of 150 to 450 microseconds, frequencies of 50 to 60 pulses per second, and amplitude of up to 5 volts or 3 milliamps in continuous or intermittent mode. One patient they treated with high-frequency PNS, which used a pulse width of 130 microseconds, frequency of 100 to 1200 hertz, and amplitude of 6.2. Only one of the 11 cases experienced a complication resulting from short extension cables requiring re-op. Okay, so there are, at least at the point of this article, they're not mentioning any randomized controlled trials of PNS for intractable postherpetic neuralgia. Of note, one randomized controlled trial used a technique called peripheral nerve adjustment, and they performed using Fu's subcutaneous needle. The needle does not use electrode placement or electrical stimulation. Rather, peripheral nerve adjustment involves the subcutaneous insertion and rotation of 4 cannular needles twice weekly for 3 weeks, and they experience some significant reductions in pain and rescue medication needs. The paravertebral nerve block, this is one that it's one of my go-to shots for thoracic spine pain because it actually hits many nerves in one shot because of the compartment that these nerves are located in. You're not near the spinal cord, so it's less invasive, and if you do it properly, you can actually get the exiting nerve root after the foramen, maybe the medial branch, as well as possibly get some spread towards the sympathetic. So you could really do a lot of good for these patients. But I'm not. That's with higher volume typically. I'm not giving huge volumes in my office. It's not an operating room. So there's a case report with success, and I have had success with this myself, but not with this patient. They're doing repetitive paravertebral nerve block with bupivacaine clonidine at T3 level catheter. Oh, they're using a catheter for 3 weeks. Patient was pain-free for 8 months after. I'm not putting catheters here in the outpatient world. So usually an inpatient thing, and I don't have many inpatients there for postherpetic neuralgia. There's another study showing they use a paravertebral nerve block to prevent postherpetic neuralgia in patients with acute herpes zoster. Lower VAS scores reduced pregabalin acetaminophen in the first 4 weeks after a single paravertebral nerve block, but the effects did not persist. By contrast, the beneficial effects of repeated paravertebral nerve block have persisted for 12 months in another study. So there is some hope with these things. I'm taking something away from this article in which I never really thought about using Botox or triamcinolone on these patients. I did think of PNS, which is probably where I'm going, or maybe a stellate ganglion block. So that being said, my advice to you is keep an open mind. Try to stay up to date on the data because there's always something new coming out, and as well as keep your skill sets up to date. PNS is a great skill set, peripheral nerve stimulation. If you're not doing it and you're an interventional pain doc, you should strongly consider doing it because I've had some major home runs. Of course, I've had some failures, but I've had patients who have failed everything you could think of, and the PNS has saved them and really improved the quality of the life. In some cases, it's cured them. I mean, I've had temporary peripheral nerve stimulation curing chronic ailments. And people say, well, it's only in the body for 2 months. But no, I've actually had it work for years afterwards. So there's definitely something to this. And always keep learning. And that's the beauty of medicine, right? We get to keep on learning new things. And in pain management, there's always something new. So thanks for listening. I really hope you guys can make it to these courses. I really try and make it a great experience. And if it's not a great experience, tell me, and I'll do my best to make it one. And thanks. Check out painexam.com. I'm going to probably add the regenerative medicine course that I just did to the Pain Exam Complete. So if you're thinking about doing the Pain Exam Complete, check that out. And thanks for listening. Please review the podcast, website, course, etc. Have a great day.
Responsible for all your decisions and actions in response to any information contained herein. These podcasts are not intended as a substitute for the medical advice of a physician to a particular patient or specific ailment. You should regularly consult a physician in matters relating to yours or another's health. You understand that this podcast is not intended as a substitute for consultation with a licensed medical professional. Copyright 2017, David Rosenblum. All rights reserved. No part of this publication may be reproduced, stored in a retrieval system, or transmitted in any form or by any means, electronic, mechanical, recording, or otherwise, without the prior written permission of the author.